Heather Bullock is a PhD candidate in the Health Policy Program at McMaster University. Heather also works as co-lead evidence synthesis at the McMaster Health Forum, where she is engaged with the development of evidence briefs and facilitating and reporting on stakeholder dialogues and citizen panels. Heather has an extensive background in healthcare policy and knowledge translation, holding progressive leadership positions. She is on leave from her current job as Director of Knowledge Exchange at the Centre for Addiction and Mental Health in Toronto. In this role, she developed and led an innovative knowledge translation initiative, the Evidence Exchange Network, which aims to make Ontario's mental health and addiction system more evidence-informed. Heather's research interests lie in how large jurisdictions implement evidence-informed policy directions in mental health and addiction systems. Her dissertation is exploring how developed countries structure their implementation efforts, as well as the process of policy implementation in Ontario's mental health and addiction system. This presentation was part of a think tank on problem gambling treatment systems integration, hosted by Gambling Research Exchange Ontario. Heather Bullock presents an overview of systems integration. This video has been narrated based on a presentation made by Heather Bullock at the GREO think tank on problem gambling treatment systems integration on January 24, 2017. To start with some background on this presentation, conducted by Heather Bullock, who works with McMaster University's Health Forum as the co-lead of evidence synthesis. The Health Forum acts as a knowledge hub focused on improving health outcomes through collaborative problem solving. Heather's focus has been more so on the broader domain of mental health and addictions, though that includes the problem gambling sector. So, with a broader focus, this presentation presents ways to conceptualize integration, and specifically a framework with which to think about integrating problem gambling within the broader mental health and addiction sector. To that end, I will also reference key findings from a report on a partnership program developed by the state of Victoria in Australia. This program aimed to develop a more integrated response to problem gambling across different service sectors by requiring gambling help services to develop collaborative partnerships between gambling help, alcohol, and other drug, mental health, and family service sectors. The report, titled Addressing the Needs of Problem Gamblers with Comorbid Issues, Policy and Service Delivery Approaches, by Kathia Martirez and Phil Townshend, was published in the Journal of Gambling Studies in 2016. The approach we are discussing here is to think about the health system in general, through a taxonomy of health system arrangements developed by Dr. John Lavis and his colleagues at McMaster University. This taxonomy is used regularly in our research efforts at McMaster and the Health Forum to perceive and classify different documents, systematic reviews, and other types of evidence. Additionally, we use the taxonomy to classify documents that go into health systems evidence, which is a searchable database of research and policy documents and other types of evidence that assist decision makers in making decisions about healthcare in general. Dr. Lavis's taxonomy outlines 3 types of health system arrangements that we can consider when discussing integration. The first is governance, the second is financial, and the third is delivery, which suggests integration at the level of clinician or practitioner. Clinical services is also listed here because we are discussing integration of the health systems arrangements rather than exclusively at the level of clinician or practitioner, meaning the way in which we are organizing, designing, and structuring the system to allow us to act in an integrated way. I will go through each of these arrangements in the next few slides to give a sense of the important factors to consider as we think about methods for structuring integrated efforts to approach problem gambling in Ontario. The first type of health system arrangements that are important when considering integration are the governance arrangements. Governance arrangements are not just policies, but structures that are separate from the service delivery system itself, yet are critical in terms of making decisions as to what should be done, how decisions should be made, and who has authority to make the decisions. This concept can be useful in 2 ways. It helps clarify the decision-making authority in a system by considering it at different levels. It also helps to determine the direction that needs to be taken when interventions and changes are desired. Every system across the world has these elements to varying degrees, although some may be stronger than others. The first type of governance arrangement is policy authority, which is the one we most commonly think of. This includes who makes the policy decisions, how they make those decisions, using what types of framework, and on what terms. When we think about policy authority, it's important to determine whether decisions are being made at a national or provincial level, or whether decisions are being made at the regional level. For example, through the development of this framework, we found that some of the important healthcare decisions are made not at the provincial level, but at the regionalized level through the local health integration networks, or LINs. And this represents a decentralizing of decision-making authority, which is important because when people want to make changes, those are the partners that will need to be involved. The second type of governance arrangement is organizational authority, which includes the organizations involved in the delivery of care. The organizations we generally think about in healthcare are often hospitals and other types of community health centers and agencies. How do these organizations make decisions, using what types of frameworks, and on what terms? An example of organizational decisions would be decisions regarding management approaches, such as developing and mandating strategies to ensure healthcare organizations are performing effectively. The next type of governance arrangement is commercial authority, which involves commercial decision-making, such as decisions made by pharmaceutical or technology companies. These types of commercial organizations can be very influential and have significant decision-making authority in terms of what can be done and how interventions in healthcare can occur. And that is the case in the majority of world countries. For example, when pharmaceutical companies don't make drugs available in certain regions, which can be a matter of saving lives. So what these organizations decide and do can impact the decisions in the rest of the system. Despite this, the commercial authority structure is often discounted, especially in what is perceived as a publicly funded healthcare system. But it's important to consider this structure when thinking about effecting change within the overall healthcare system. The next type of governance arrangement is professional authority, which includes the decision-making at a professional level. This would entail decisions such as who gets into specialized college or university programs, leading to who gets to be a psychologist or a medical doctor or a nurse. Those decisions are not made at the provincial level, nor at the regional level. Those decisions are made by the professional bodies that govern those professions. This means the professional authority is an important area for integration because they are responsible for training practitioners. And if the goal is for people in the healthcare field to think and work in an integrated way, it may be more effective to address the concept of integration at an early stage, at the level of training these professionals before they enter the workforce, so that they already have the inner belief that it is important. And this is particularly relevant to the problem gambling sector, as studies such as the report on the Australian Partnership Program show that one of the major challenges to addressing problem gambling is getting people to recognize it as a priority. Finally, the last type of governance arrangement is consumer and stakeholder involvement. This is not referring to consumer and stakeholder involvement in care, rather it is consumer and stakeholder involvement in the governance decisions in general. This includes whether consumers and stakeholders are participating in decisions about future policies, such as the mental health and addiction strategy in Ontario. What are the best ways to integrate consumer and stakeholder involvement into these kinds of decisions? And additionally, how can they be integrated into oversight and monitoring decisions? For example, ombudsmen or people who have a role in monitoring the system, acting as an independent monitor on what's happening within the system. This is another governance arrangement that's important to consider. So, in terms of governance arrangements, the critical question would be, who has their eye on problem gambling services at all of these levels we just discussed? Now that we covered the types of governance arrangements, the second type of arrangements are the financial arrangements. These are the structures which involve the financial aspects of the healthcare sector. Not simply funding, but also decisions on how the funding is dispersed and how the money is raised. For example, some funding for problem gambling treatment is raised from the gambling sector itself, and this funding may not support other areas of healthcare, which has significant implications for integration. Within the financial arrangements, there are the financing systems, which are the mechanisms used to raise revenue. These mechanisms include things like taxes or revenue from profit-making endeavors such as gambling, or co-payments by patients for medications. These mechanisms are used to raise revenue to fund a particular health system. There are also funding organizations within the financial arrangements, which are the mechanisms used to pay for services from healthcare organizations, such as hospitals, within a health system. These mechanisms include the fee-for-service model, targeted payments, etc. Next, there are the mechanisms for remunerating providers. These are the mechanisms used to pay for services from individual providers within a health system. For example, doctors are funded through a different mechanism from nurses or social workers or private psychologists, and this all has an impact on integration in terms of assessing the levers that exist in a system, who the targets of integration are, how they are motivated, and who makes the decisions about these financial aspects. Financial arrangements also include the mechanisms for purchasing products and services. For example, how do we decide how many MRI machines to purchase? How do we decide what's important in terms of the products and services in our system? And the last element of financial arrangements are approaches for incentivizing consumers to participate in their care. There are a multitude of options, from providing financial incentives to charging penalties if they don't meet certain objectives. There are many different ways that we can work with consumers directly rather than intervening through a more formal system of care. We sometimes neglect to consider these kinds of options because they are not common in Canada. It is much more common in countries like the United States through insurance plans. Finally, the type of arrangements we discuss most are the delivery arrangements. These include elements such as how care is designed, as in, what approaches are being taken to ensure care is delivered in a way that is sensitive to the needs of consumers. This can include aspects such as accessibility of care and timely access to care. Deciding what is prioritized in terms of accessibility has impacts on how accessible other services are, because of course there's only so much money in the pot we have for healthcare. Secondly, within delivery arrangements, we consider by whom care is provided. For example, what organizations are currently responsible for delivering problem gambling services? If the goal is to integrate care, does that mean the organization currently delivering that kind of care will change? Will professionals working in youth services that aren't currently trained for problem gambling begin managing that care? And what are the potential impacts of these kinds of changes? It's very important to determine both who is currently providing care, and if the goal is to integrate care, who might be responsible for that care in the future, and what are the financial impacts of that? The next delivery consideration is where care is provided. This includes the more physical elements, the structures of care delivery. For example, in the case of integration, there's the concept of co-location, where various care professionals are in the same location, so that a person receiving one type of services can walk down the hall and get another type of care provider. This integration of the physical structures themselves is not enough, but it can be a very important component. Finally, within the delivery arrangements, we consider with what supports care is provided. Again, this concept can be overlooked or thought of in a negative sense, such as the challenges of technology entering the healthcare sector, for example, with electronic health records, or the challenges of identifying the facilitators that are going to help in the delivery of the intended integrated care. It's important to consider whether things need to be done differently to enable the provision of care in an integrated way. This care may have been delivered through separate systems before, using separate data systems that may not work together. This kind of challenge is common in the provincial health system, across regional organizations like the LHINs, or across different service providers. That challenge hasn't entirely been overcome yet, and it's very important when discussing the goal of integrating care. Now we've just discussed all the different types of decisions on all the different levels that can be made in terms of integration. We think about integration as a somewhat straightforward concept, but when we examine it at the decision-making level and all the levels involved, it's actually very complicated. And it allows us to understand the challenges faced by those who are involved in the decision-making, because you can't intervene at every level and do everything at once. So, what are the best ways to prioritize? Where should investment be focused? This is where we look to what the literature says, to look for evidence as to what is most important when thinking about integration. Now let's consider some of the broader provincial initiatives that are taking place in terms of integration. For example, we should ask how the problem gambling field should be involved with current and future provincial mental health and addictions initiatives. These provincial initiatives are relevant mainly at the governance level, but can cut across many sectors. For example, in Phase 2 of the Provincial Mental Health Strategy, one area of focus is the anti-poverty agenda, which has impact on activities within the healthcare sector, the child and youth sector, and even the justice sector. The policy initiatives that are related to problem gambling services need to be identified, and if the goal is to have an integrated system, the problem gambling services organizations need to consider how involved they want to be at the governance level in the implementation of provincial initiatives. There may also be some risks involved as sectors and organizations move out of the silo structure. Integration brings challenges that can affect people on a personal level, by making them feel threatened on a professional level, by removing a certain responsibility and assigning it to someone else. Integration decisions can personally affect people, so that needs to be recognized and managed. And there are risks from a financial perspective as well, for the regions, funded agencies, or individual service providers involved. Now, it's important to consider the benefits of integration as well as the risks. We think integration is a good idea, but what are the downsides? We should be clear about those downsides from the outset so that integration efforts can be designed in a way that mitigates the risks and downsides as much as possible. It's important to consider integration according to the type of health system arrangements involved: governance, financial, or delivery. One of the challenges with integration is that if we just intervene in the service delivery side, other forces might, at the same time, be working against integration. Conversely, these forces could be influenced to support integration. These could be financial forces, policy forces, or others. I've listed several forces here that could potentially be important when we're thinking about integration of problem gambling with other areas of health and particularly mental health care. They include training for problem gambling and other mental health and addiction service providers, how and where people access the service system, screening and assessment for problem gambling, but also for related conditions, prevention and promotion efforts, treatment, given that both cognitive behavioral therapy and motivational interviewing are effective for problem gambling as well as other mental health and addiction issues, and finally, the data systems that underpin problem gambling services at the provincial level and at the agency or local level. Each of these could represent a target for integration, but at the very least should be considered when moving toward integration. Here are some key elements of the Victorian Initiative. The program was started in 2008 by the Victoria Department of Justice, which is now the Victorian Responsible Gambling Foundation, or VRGF, with the aim of developing a more integrated response to problem gambling across different service sectors. The program requires gambling services to develop collaborative partnerships between gambling help, addictions, mental health, and family service sectors. We refer to this as a no-wrong-door approach to service delivery. Flexible service responses such as outreach, secondary consultation, single sessions with problem gambling specialists, co-counseling, and co-location are provided by all gambling help agencies in Victoria as part of their standard service delivery. The Australian Partnership Program Report offered 5 principles to assist in cross-sector collaboration, based on their experience of implementing the partnership program into gambling help services. They draw on the literature of cross-sector collaboration and have been developed specifically for the gambling help sector. Please see the report itself for the full overview of the 5 principles. But for our purposes, we are looking at how each of these principles fall into one of the 3 structures we've talked about: governance arrangements, financial arrangements, and delivery arrangements. Firstly, establishment of an authorizing environment, which falls within governance arrangements. This speaks to the need for support from some level of authority. In Ontario, this could be at the provincial level or regional at the local health integration network level. Systems integration, in this sense meaning the integration of service components including screening, assessment, and treatment planning. These fall within delivery arrangements and affect how people are streamed to problem gambling or related services. Social capital refers to how the service providers interact and the quality of their relationships. This principle falls mostly within delivery arrangements as well. However, it also includes some elements of training, so it could fall within the governance area too. Co-location falls within delivery and affects where people access services for problem gambling and related mental health and addiction issues. Joint training primarily impacts the financial arrangements and includes the structure and cost for cross-training service providers. So it's clear that when it comes to the true functioning, practical side of integration, the focus is very much on the delivery arrangements, integrating screening, assessment, and treatment services, co-locating services for co-occurring or similar conditions, and providing cross-training for service providers. But it's important to emphasize the establishment of an authorizing environment as the first step. This is because the system will resist the change and the integration that's taking place. The system wants to remain as it is. So you have to push against it from the governance, financial, and delivery arrangements if you want to make that change. As an example of an important integration initiative here in Ontario, I'm currently working on a scoping review for the Medical Psychiatry Alliance, which is collaborating with Trillium Healthcare on a major initiative in Ontario to integrate mental health and addictions care with care for other physical conditions. This initiative began about 2 years ago, and they're now working to evaluate similar initiatives that are taking place across the province. The objective of the scoping review is to identify the core components of an integrated medical psychiatric model of care, to provide a benchmark against which to evaluate each initiative. Our team of students and 2 full-time researchers at McMaster are conducting this scoping review, slated to be published in 2017. This work should provide some important lessons on the best practices and strategies for integrating different kinds of care. On this last slide, I'm sharing some lessons learned from research that the McMaster Health Forum undertook on designing integrated approaches to support people with multiple physical health conditions. Some of these lessons are similar to the 5 principles from the Australian Partnership Program report, but they also include the fact that we need more evidence-based guidance, as right now there isn't any evidence-based guidance on how to integrate across these different physical or mental health conditions. The findings from this work also include the notion that we should embrace approaches to self-management, meaning people with multiple conditions are going to have to take an active role in helping to manage their own health and wellness. It's important that we are more clear about how they can do that and what we determine to best support them to do that. Additionally, the evidence suggests that there needs to be greater communication and collaboration among practitioners and with consumers of services. There's not enough communicating amongst practitioners or with the consumer who is present and has the multiple conditions about how these conditions interact, what they should expect, and where they might go to get support for the other conditions. And another key finding is the importance of investing more in health promotion and prevention, so that we don't get to the point where we're dealing with these multi-morbidity concerns, rather that we try to prevent them from occurring in the first place. So these brief lessons from Australia and Ontario help us understand what we need to consider when we talk about designing initiatives to improve the integration of problem gambling services with mental health and addiction services in Ontario. Full reports and links to resources and items mentioned in this presentation are available in the GREO Expert Panels Resource Center, accessed through this webpage. Thank you for listening to this presentation, An Overview of Systems Integration by Heather Bullock, which was part of the GREO think tank on problem gambling treatment systems integration on January 24th, 2017.